Okay, so today I'll be going over the anatomy of the wrist. Great. The wrist is quite a complex joint. There's quite a few bones that make up the wrist and perform lots of movements. The main joints that contribute to the movements of the wrist are the distal radius and the distal ulna. The ulna doesn't quite articulate with the carpal bones, but I'll get to that in a minute. And then there's 2 rows of 8 total carpal bones. So the proximal carpal bones from the ulnar side to the radial side are the triquetrum, and anterior to that is the pisiform. Then you've got the lunate and scaphoid, and then in the proximal row you've got, on the ulnar side, the hamate, it has a little hook there, capitate, trapezoid, and trapezium under the thumb. So these are the joints of the wrist. The distal radial ulnar joint is between the radius and the ulna, and it's a pivot joint which allows for pronation and supination of the wrist. The radiocarpal joint is between the radius and the proximal row of carpal bones, and that is a condyloid joint which allows for flexion, extension, abduction and adduction of the wrist. And the midcarpal joint is between the carpal bones. It's a bit more of a complex shaped synovial joint. It's got features of both a gliding and a condyloid joint, which also provides flexion, extension, abduction and adduction of the wrist. The reason the ulna doesn't articulate with the carpal bones is because of this triangular fibrocartilaginous complex. It's got a few structures in it that help to sort of absorb and transmit forces from axial load of the wrist, and also just provide strength to the wrist in its movements. So it consists of the articular disc, which is what transmits and absorbs the forces, the radioulnar ligaments, which stabilize the radioulnar joint, ulnocarpal ligaments, which help to keep the wrist bones with the wrist. Sorry, the carpal bones within the wrist during pronation and supination, the extensor carpi ulnaris tendon and sheath, and then meniscal homologue, which is some loose connective tissue. There's quite a few ligaments of the wrist. I'll go through volar, dorsal, and then briefly intrinsic ligaments. The 3 main portions of the volar extrinsic ligaments are the radial collateral, the ulnar collateral, and this palmar radiocarpal ligament, which is made of a few smaller ligaments. And those are the radioscaphocapitate ligament, the long and short radiolunate ligaments, and the radioscapholunate ligament, named for the bones which they attach. And on the ulnar side, you've got the ulnar collateral, which is shown in the bottom right image, but also the ulnolunate and the ulnotriquetral ligament, and those 3 are part of that triangular fibrocartilaginous complex. And then the ulnocapitate ligament, which is quite a bigger ligament down the bottom. Oh, don't know if you can see the mouse. That's it there. And then on the dorsal side, it's a bit simpler. There's 4 main extrinsic dorsal ligaments. They are the dorsal intercarpal ligament, the radiotriquetral ligament, the radiolunate ligament, and the radioscaphoid ligament, all helping to stabilize the wrist joint. And there's many intrinsic ligaments, mainly just interosseous ligaments, that connect all the carpal bones, but the 2 ones of highest clinical importance are the scapholunate ligament and the lunotriquetral ligament, as these are important in lunate and perilunate dislocations, which I'll talk a bit about at the end. And the muscles that provide movements of the wrist are all sort of the flexor and extensor compartments of the forearm. So flexion is provided by flexor carpi ulnaris and radialis, and a bit of assistance from flexor digitorum superficialis. Extension is also provided by the extensor carpi radialis longus and brevis, extensor carpi ulnaris with assistance from extensor digitorum. Adduction or ulnar deviation is provided by extensor carpi ulnaris and flexor carpi ulnaris, and abduction or radial deviation is provided by abductor pollicis longus, flexor carpi radialis, and extensor carpi radialis longus and brevis, as shown in the pictures there. And for innervation blood supply of the wrist, the median, radian, and ulnar nerves all give branches of innervation to the wrist. From the median nerve, we've got the anterior interosseous branch, the radial nerve gives the posterior interosseous branch, and the ulnar nerve provides deep and dorsal branches to the wrist. And the blood supply is provided by the ulnar and radial arteries. This is sort of a bit of a picture of a dissection of the flexor compartment of the wrist. You can see the ulnar artery and nerve here, the radial artery here, and this is the median nerve going into the carpal tunnel just there, and lots of tendons. Great, so that's mostly it for the basic anatomy of the wrist. I just wanted to go over some common orthopaedic risk presentations just to tie it all together. So the first is a distal radius fracture. It's the most common orthopaedic injury, and it's mostly due to a fallen outstretched hand, but can also result from high energy mechanisms such as a car accident or a fall from a height. There are many different types of distal radius fractures, and there's quite a few eponymous names. Shown in the picture here is a Colles fracture, sort of appears like a dinner fork deformity. It's an extra-articular distal radius fracture with dorsal angulation. And similarly is a Smith's fracture, which is also extra-articular but with volar angulation. Another one is a Barton's fracture, so that's intra-articular fracture with dislocation of the radiocarpal joint. It's most commonly volar but can also be dorsal. And this die punch fracture is a depressed fracture of the lunate fossa, where the lunate has sort of pushed into the radial head and pushes into the articular surface of the radius. Treatment is depending on the injury and the extent of displacement, but you can have a closed reduction with cast or splint, you can fix it with K-wires, with an open reduction internal fixation or external fixation, and there's a few complications resulting from the injury itself and from treatment. So you can get median nerve neuropathy from either. You can get extensor pollicis longus rupture from either a non-displaced fracture causing attrition or ischemia of the tendon, or if you've got prominent dorsal screws from a volar plate that can irritate the EPL and cause rupture. And similar with the FPL, if you've got a distal volar plate and you've got prominent screws from the plate, that can cause tendinopathy and rupture of the flexor pollicis longus. The next one I will talk about is the scaphoid fracture. So it's the most commonly fractured carpal bone, and it's also most commonly caused by a fallen outstretched hand. The reason it's of such clinical importance is because it receives retrograde blood supply. 80% is from this dorsal carpal branch of the radial artery. The other 20% is from this superficial palmar branch of the radial artery. And because you've got two arteries providing the same bone, it creates a watershed area, which is provides a poor environment for fracture healing. You can sort of, I think, separate the scaphoid bone into 5 parts. The most proximal part, if you have fractured it, it's got a 100% risk of avascular necrosis, whereas if you're in the 3rd, 5th, which is around the waist of the scaphoid, your risk of avascular necrosis is 33%. It'll present with tenderness over the scaphoid tubercle, which is on the palmar surface, or over the anatomical snuff box here dorsally. Treatment, again, is either with cast immobilization, K-wires, or open reduction internal fixation. And the final presentation I'll talk about is a lunate dislocation. So there's sort of 2 types. You can have actual dislocation of the lunate. So the carpal bones are in normal alignment with the radius. It's just the lunate that's out of place. Or you can have a perilunate dislocation, which is the lunate is in normal alignment with the radius, but the rest of the carpal bones are dislocated comparatively. The problem with this is that the dislocation often occurs into the carpal tunnel, and you're at high risk of a median nerve compression. The X-ray findings are kind of interesting. So on AP, you can see the lunate here is sort of a piece of pie or a pizza shape. It's triangular because it's sort of rotated there. And you can see the lines between the carpal bones aren't continuous, because you've got that displacement of the lunate there. And if you do so that's meant to be a lateral view. If you do a lateral, it can help differentiate whether it's the lunate that's displaced or if it's the rest of the carpal bones. And if it's the lunate, you get this spilled teacup sign where it's sort of tipped volarly, and it looks like it could be a little teacup spilling over. Treatment needs to be rather rapid. So this is from what Mr. Ang told us the other day. So you want urgent reduction within 6 hours to prevent median nerve compromise, and then you want, within 3 days, you want to operate with an open reduction, and you want to repair that scapholunate ligament. You may need to perform internal fixation as well, or carpal tunnel release, depending on the extent of the injury and the structures involved. And that's it.